there are some fun details here that I think I can give you that will help remove a lot of the confusion and anxiety regarding neuro, and I'm excited to do that for you. So let's start with our first syndrome here, and we'll have a few different examples of the way it can present. You'll have somebody maybe middle age or a little older who's got this progressive numbness and weakness in their feet coming up, and you probably already know where I'm going with this. They recently had a recent diarrheal illness or maybe a recent viral infection. And then the key that I wanted to point out in this example here is that when you do the exam, they have absent lower extremity reflexes. Another example, maybe it's a younger person who recently had bloody diarrhea, and now they've got this ataxic, wobbly gait, and again, absent reflexes. And what do you expect to see on these two patients if you did their CSF? And if we see what we expect to see, how can we confirm it with a diagnostic test? And lastly, how do we treat it? So this is Guillain-Barre syndrome, and like you probably already are aware, preceding infection, loss of proprioception, ataxia, wobbly gait. These people also have a lot of weird sort of dysautonomia symptoms, and this is something they may try and get you with on the shelf to confuse you, because these people can have things like a fast heart rate or urinary retention or a blood pressure that's kind of spiking and dropping, and it can almost try and confuse you as if it's a pheochromocytoma or something. But just be aware that people with Guillain-Barre can have these weird autonomic fluctuations in their symptoms. And a hallmark of this clinically that I certainly didn't realize until I was on the neuro rotation is that they have absent deep tendon reflexes. So when I see this in a question, I almost immediately go to think this is Guillain-Barre syndrome. And the characteristic CSF profile is to have increased protein and a low white blood cell count, and we call that albuminocytologic dissociation, and that is also fairly hallmark for Guillain-Barre syndrome. And this is something that people forget, and the best way to diagnose this once you've got the above information is to do an EMG study or a nerve conduction study to sort of prove that there's demyelination going on. And then you should know the treatment. This is a great example of something that's frequently tested, which is either IVIG or plasmapheresis. Either one is appropriate. But notice here that steroids are not a part of the treatment. And lastly, just be cognizant that if they're giving you tidal volumes or vital capacity that are going down, or the forced inspiratory force is going down, this is somebody who may need intubation. So just be aware that that may be required of you to know. Another syndrome we can go through different cases with is maybe somebody who had a motor vehicle wreck a few years ago, and they've got a bent upper thoracic spine, and they come in with this worsening weakness in their hand muscles bilaterally. Almost sounds like carpal tunnel if they were just talking to you about the weakness. Then you do a neuro exam, and there's the loss of temperature and pinprick sensation along one dermatome, and then you also notice muscle weakness in that same region. And another fun way to approach this one is maybe you've got somebody who they're only telling you about progressive weakness or motor symptoms, but then they subtly mention to you on their physical exam that you see burns on their fingers that the patient is unaware of, suggesting again loss of sensation. So now we're talking about Syringomyelia, so I can't say it, whatever. And the keys to this are going to be a history of trauma, back pain, and progressive symptoms, and maybe some kyphosis. And the hallmark again is loss of pain and temperature sensation and a cape-like distribution. And be aware that it can progress to motor symptoms and even ultimately to loss of bowel and bladder control. They like to try and mix this up with ALS for you, but you got to remember that anybody with ALS is not going to lose any kind of sensation. But people with ALS on the shelf at least can present with this cape-like distribution of muscle weakness and motor symptoms, and they like to trick you with those two conditions by giving you that distribution of motor weakness. But again, loss of sensation should lead you directly to Syringomyelia and rule out ALS. And again, know your dermatomes, because I remember on my shelf, they maybe gave me symptoms and they gave me an obvious vignette, and then they wanted me to tell them which dermatome was involved based on the pattern of numbness. So just know C6, C7, and C8, maybe even T1, and which parts of the arm, finger specifically are involved. And lastly, just be able to diagnose this condition using an MRI. So another example, just sort of talked about it. Now we're talking middle-aged or elderly, and they're giving you these vague signs of muscle weakness and some atrophy and lower motor neuron symptoms. And then they've given you all these lower motor neuron symptoms, and somewhere in the vignette there's a positive Babinski sign. So now you've got a mixture of upper and lower motor neuron symptoms. Or maybe you've got somebody with eye weakness and ptosis and maybe some dysphagia, and maybe they're trying to show you that this is a recent stroke or make it sound that way. And then you look somewhere and the exam is describing a flickering of muscle somewhere, which is a fasciculation, a lower motor neuron sign. So again, you're mixing the two. And the key that I'm trying to make here is that you're going to have very vague questions giving you either a progressive peripheral motor weakness neuropathy picture or a stroke syndrome, and then they're going to throw you a curveball mixing upper with lower motor neuron findings. And if you get this, you're looking at amyotrophic lateral sclerosis. And again, no sensory symptoms and also no autonomic symptoms. And remember your upper motor neuron findings, remember your lower motor neuron findings, and know when they're being mixed up on you. And I've already talked about how vague it can present to you. And I mentioned sort of also that they can come in with a progressive carpal tunnel-like neuropathy sort of syndrome, or even a cape-like distribution of their weakness. But again, it's going to be that mixing of upper and lower motor neuron things that should help you discriminate it. And if they're trying to confuse you with Syringomyelia, they may not tell you that there's a loss of temperature sensation. They may leave that out. They may simply give you weakness with mixed upper and lower motor neuron findings, and that will be tricky, but just know those upper and lower findings and be able to use them. And more presentations there, kind of went over those, but one thing I wanted to just throw on here to remind you or maybe tell you about is a pseudobulbar effect is not necessarily pathognomonic for this condition, but can be associated with these symptoms, which wouldn't be associated with Syringomyelia, for example, which is when you have inappropriate crying or laughing that they can't really control, and they're probably upset about too because they don't mean to do it. So now we'll run into multiple sclerosis, and I think the definition is relatively straightforward. It's autoimmune demyelinating, and we're talking about separate lesions that are separated in time. And clinically, they're not going to have a linear progressive course, but more so they're going to have a flare-up and new deficits that get better, get better, get better, followed by another relapse. One of the hallmarks is optic neuritis, and the physical exam finding that they love to give you is somebody who you shine a pin light into their eye, and instead of constricting, the pupil dilates, which is called an afferent pupillary defect. They may also describe to you loss of vision in that eye or pain with movement. These people also just develop, I don't think I need to go over this with you, just very random neuro findings. They can be really anything from a neuro perspective, symptom-wise. Internuclear ophthalmoplegia, you probably already remember this. You can probably recognize if it's described to you. You take the finger, shift it side to side, and the one eye can't adduct, and the eye that isn't adducting is going to be the one that has the lesion on the medial longitudinal fasciculus. I always forgot that, so I wanted to put it in here and remind you of that, and to remind myself of that. And if it gets bad enough, and actually at some point in the disease, most people will get bowel, bladder, or even sexual dysfunction. And one nice, nasty symptom that they love to give you on the shelf is when somebody describes a shock-like sensation when they bend their neck that shoots down their spinal cord. You only see that with multiple sclerosis or vitamin B12 deficiency. And it's a very vague symptom that is relatively hallmark for those two conditions. And remember that these people are also very sensitive to heat. They don't, going out in the sun will make them sweat and feel super hot when it wouldn't used to. That may be something they present to you in the vignette. Know the MRI findings, multiple demyelinating lesions, and if somebody's having an acute flare-up, you give them IV steroids. And you could also know that you treat them with interferon beta if you want to go for gold on the shelf. So if we're talking about MS, I think it's important to talk about B12 deficiency because I think the neurologic findings of the two conditions can be presented to you in a way where it can be hard to discriminate between them. So, kind of going in, if you are lucky enough to have a vignette that gives you a good history, then you may be told that the patient isn't eating meat, they're vegan, or they have a history of type 1 diabetes or hypothyroidism, some kind of autoimmune condition, which would suggest that they might have a pernicious anemia with anti-intrinsic factor antibodies or atrophic gastritis, or if they have a history of Crohn's disease with a terminal ileum that doesn't work. These are all suggestions that you may have a vitamin B12 deficiency. But remember, it takes years or several months at least for this to develop. And the presentation for B12 deficiency, in contrast to multiple sclerosis, should be progressive and it should not have fluctuations. They should have symptoms that start usually in the posterior column with loss of vibration and position sensation, maybe some ataxia or a high stepping wobbly gait. And, again, they shouldn't get better followed by worsening. They should just get worse and worse and worse. And ultimately, they can develop motor function abnormalities and loss of bladder and bowel control. So you can imagine how, if I don't give you a lot of information, I can make these two conditions, this and MS, very, very hard to discriminate between. And, another thing that can confuse you is that the more I've read about this, the more I see that B12 deficiency neurologic findings can actually precede the megaloblastic anemia that we've all become so comfortable associating with it. Then, for the diagnosis of B12 deficiency, you can do a few things. If you think that they have pernicious anemia, you could do an anti-intrinsic factor antibody assay, or you can measure a B12 blood level, but the B12 blood level is actually not as sensitive as measuring the metabolite levels. But you really, at least from what I understand reading about this, you shouldn't order these metabolite levels, the methylmalonic acid and homocysteine levels, right off the bat. It would be more so in somebody with a low normal B12 level who you have a high index of suspicion for vitamin B12 deficiency in. But more so on the shelf, I don't think they're going to expect you to know that kind of detail. I think they're going to tell you what could you measure to get an idea if this patient's B12 deficient. And just remember, these two enzymes or metabolites, would be elevated in B12 deficiency. And importantly for you to know as well, if you treat their B12 deficiency, you can use these metabolic markers and a decrease in their level as an indication for improvement. And I think also you got to talk about folate if you're talking about B12. And on the shelf, they love to give you people who are either old and malnourished or more commonly alcoholics. So anytime you see an alcoholic, you should be thinking about two deficiencies: folate deficiency and thiamine deficiency. If they have a megaloblastic anemia and they're an alcoholic, I bet you they're folate deficient. And no neurologic findings. That is key. And how do we diagnose it? This is probably not going to be on your shelf, but you can use a serum folate level. But you should know that if you measure someone's folate level, it can likely be normal if they just ate a meal. So somebody who you just hospitalized off the street who's an alcoholic, if they just ate some bread and eggs, they're probably going to have a normal folate level. And if you wanted to get a more accurate picture, you could do a red blood cell folate level. If somebody has a combined folate and B12 deficiency, this is tricky. Again, the key here would be the neurologic findings. And if you give folate without correcting B12, you're going to worsen. The key here is to worsen neurologic symptoms. And that may be something that they tell you in the vignette, is that I gave them treatment with folate and they got new neurologic symptoms. And when you look at their blood, if you gave them folate, their megaloblastic anemia is actually going to get better. So an improved megaloblastic anemia with new neurologic symptoms suggests an underlying B12 deficiency in somebody who you treated a folate deficiency in. That's a mouthful, but it's a concept that I recommend you know for your shelf.